Hello, my name is Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota. Today, we'd like to cover the topic of nursing home care. In terms of disclosures, I have no conflicts of interest. This project is supported by HRSA and its Geriatric Workforce Enhancement Program. The objectives today are to firstly report who needs nursing home care. We want to list the challenges to nursing home care and go over the funding for nursing home care. So you might ask, why do you need to learn about nursing home care? As it turns out that just about half of the population at some time in their lifespan will go to a nursing home either for short or long-term care. This is a highly vulnerable population, mainly driven by the fact that they have different functional limitations or impairments, whether they be cognitive or physical limitations. For the long-term care residents in particular, there are a lot of health disparities that need to be considered. And there's also an issue of ongoing increases in medical complexity. There are unique issues in long-term care, such as antibiotic resistance bacteria, as well as infection control challenges. And finally, there's a very high rate of acute care recidivism, which is both costly to the older adult and who becomes more and more exposed to iatrogenic disease in nursing homes and hospitals, as well as the overall cost. So we can ask who needs nursing home care, and typically these are people with transient or permanent impairments in physical and or cognitive functionality. We have to distinguish short versus long-term care. Typically short-term care is within 3 months, and thereafter it becomes long-term care. 90% of individuals in long-term care have over 3 activities of daily living that are impaired. And generally speaking, 60% of residents need some form of feeding assistance, either as a setup or direct feeding. If we look at what nursing homes, in terms of their profile, there's a lot of variation for sure, but quite a few of them have multiple chronic conditions. There's a lot of memory impairment in long-term care facilities, and there's a lot of behavioral disorders. Quite a few individuals will either acquire pressure ulcers from the hospital or in the facility. A lot of times these are the consequence of their frailty and multiple medical conditions, but sometimes it's also due to neglect. A third of individuals, if not more, will fall annually in the long-term care facility. And 60% of individuals in long-term care have bowel or bladder continence issues. In terms of the overall aspect of how nursing homes are funded or administered, 70% of them are for-profit facilities, a quarter of them are not-for-profit, and the rest are typically veterans facilities. The size of the facility may change, according to whether they're an urban-based or rural. So some urban or rural facilities could be 25 beds, whereas some urban facilities can be in the 1,000-bed category. But on average, it's about 100 beds per facility. Half of those long-term care facilities are part of what we call a corporate chain. There are many challenges in nursing home. Certainly staff shortage, which has been exacerbated by the COVID pandemic, and also exacerbated by underfunding of long-term care facilities. But there's both nursing staff, other staff, as well as providers that I recall a statistic that only 1 out of 10 doctors ever go to a nursing home to see patients. The patients or the residents tend to be sicker these days in nursing homes, and there's a lot of antipsychotic use, mainly to control behavior, which is not always appropriate. Antipsychotics are used for sedation purposes in most cases, and so with staff shortage, it often becomes more convenient to push antipsychotics for a sedate patient that staff don't have to deal with as much, I should say. There's also access issues, particularly in rural nursing homes where you don't have rapid turnover laboratory results, often causing delays in care. In terms of financing nursing homes, the bulk of it is through public aid and Medicare, although there are other options such as commercial insurance. The veterans homes that I was mentioning, there's county insurances in many cases, long-term care insurance that perhaps you may have paid into, and then self-pay. The annual cost of nursing home care is absolutely staggering. And as you can imagine, the vast majority of the American population cannot afford it. And so you need these insurance financial backups in order to provide both short-term and long-term care. Medicare A will support nursing home, but in a very limited fashion. It's a 100-day benefit. You have to be in the hospital for 3 days. And the first 20 days are paid by Medicare, but thereafter it becomes a copay. And that's a lot of times when a physician will get a call from the nursing home and say, we need to discharge Mrs. Jones because she no longer wants to pay for her rehab. In terms of quality measures, we need to consider both the short-term stay as well as the long-term stay residents and what impacts them. Well, certainly rehospitalization is a big deal. Hospitals are penalized for patients that come back within 30 days, and nursing homes tend to be a large source of those types of what we call bounce-back patients. But it's also important for quality measures, both in long and short term, to think about how much or what percent of the residents are on antipsychotic medications. The evidence-based medicine suggests that it should be no more than 10% of the population. And so if a particular facility has more than 10% of its residents on antipsychotics, you have to start thinking that that may be inappropriate and overprescription of antipsychotics. Falls is a big issue, both in the community and in long-term care. In terms of medical care considerations, one of the things that we understand is that residents of long-term care or skilled nursing facilities have multiple chronic conditions, thus complicating a lot of their acute upon chronic illnesses. The older adults in particular will present with atypical presentations of very common illnesses. And so, for example, COVID may present as abdominal pain rather than a cough. There's also a lot of physical and cognitive frailty, which becomes a bigger issue when individuals are under stress, such as a post-fall incident or febrile illness, for example. And finally, there's always a big issue of autonomy of the older adult or the resident of a nursing home, and then the either potential conflict or control through durable powers of attorney. We also need to consider points in one's life, particularly in a nursing home, as to when you transition from curative to comfort care. And that's often a difficult transition for people to either both consider or to agree to. There's also issues with group housing in a sense of disruptive behavior, recalling that about 30% of residents in long-term care facilities have some sort of psychological problem. There are a lot of preventive medicine challenges. There's nosocomial infections such as Clostridium difficile. There are a lot of falls in long-term care and, like I say, acquired pressure ulcers. Often not spoken about is the social isolation and loneliness that occurs in long-term care facilities. So with these in mind, the question becomes, what can you do to improve long-term care? Well, certainly and foremostly, having a good transition of care, particularly if you're in the acute care setting or hospital setting, to make sure that you have both a written and a verbal plan. So calling up the facility that would be accepting the patient. And then also provide your contact information so they can call you if they have any questions. You also want to engage and communicate with family members. They oftentimes are out of the loop, and so it's important to, even if it's a matter of reiterating some of the plans, because people tend to forget or they don't absorb everything that has been mentioned to them in the hospital. You also want to encourage interprofessionalism. Team-based care is better than individual care by each provider, and so it's always good to coordinate your assessments and management plans with staff. And then finally, it'd be important for all participants, family members, community members, residents, staff, providers, to promote small, short duration quality improvement projects to try and make things better. The practice of the geriatric 4Ms is essential for good quality outcomes, and we recognize those as what matters to the older adult, trying to avoid harmful medications, enhancing or identifying problems with mentation, whether they be delirium, dementia, or depression. That early recognition and intervention can be very, very useful. And then finally, to consider mobility plans for nursing home residents, particularly with a focus of fall prevention. So just to say one more comment about the funding of nursing home care. Medicare will provide short-term benefits. I had mentioned it's a maximum of 100 days per event. It's renewable. Medicaid is the bulk of nursing home funding through short and long-term support. Oftentimes people are, if they're middle class or even wealthy, will have to spend down and sell their home in order to become eligible for Medicaid. They have to basically become impoverished. And then commercial insurance will cover short-term stays, but you have to have proof that you're making progress. In terms of veterans, there are what they call community life centers, which are the equivalent to long-term care facilities, as well as state veteran homes. As I mentioned, the Indian Health Service does not support long-term care. So in conclusion, it's important to recognize that multi-complexity prevails amongst nursing home residents. Nursing facilities are highly regulated, thus causing a higher burden of care and work than occurs in any other setting. In fact, nursing homes are the most regulated industry next to nuclear energy. There are challenges with marginal funding of facilities because of the dependency on public aid. And there's also a lot of physical work, just the task of transferring patients or residents and helping them with feeding and so forth. As a consequence, there's a lot of high staff turnover. We also know that quality care is elusive even with the best of intentions. Those can involve iatrogenic, unintentional health exposures such as to infectious agents. And then finally, we need to always keep in mind the importance of maintaining the dignity of the resident and to constantly support resident autonomy. So I want to thank you for your attention, and I hope you do a little deeper investigation into the different aspects of nursing home care. I'm Dr. Donald Jurovich, and I'm a professor of geriatrics at the University of North Dakota. Thank you for your attention.